Okay, give me 1 minute, please. Just
Yes.
1 minute. Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 20A, which is Hematology Transfusion Medicine. We are streaming live from AIIMS Jodhpur via Kolkata. A very important, very essential, and very basic topic of which many of us have not much knowledge, which is blood group system, basic and advanced. And to speak on that, we have somebody who's an expert in this. We have Dr. Anubhav Gupta, who's an MBBS and MD in transfusion medicine from the famous PGI Chandigarh. He's also done a PGDHHM. Presently, he's an assistant professor in the Department of Transfusion Medicine at AIIMS Jodhpur. To his credit, he's got multiple publications in national and international journals. His areas of interest is apheresis, immunohematology, cryopreservation of stem cells, stem cell harvesting, artificial intelligence in transfusion medicine. He has been awarded the Harold Gunson Fellowship and the ISBT at 2021. Before I ask Dr. Gupta to start, let me request all of you to keep your mic muted, your camera off, and please don't share your screen with this. But let me request Dr. Anubhav Gupta, sir, please share your screen. Let's start. Thank you so much.
Thank you so much, Nadeem sir. It will be my pleasure to be a part of PURS through Nadeem sir. Thank you, sir. Nadeem sir, my screen is visible, sir?
Yes, sir. Please share your PPT. That's it.
Okay. Good evening, friends. So, I will be talking about the blood group system, the basics and advances. So, basically, it is a very broad topic. So, I'm just covering the nomenclature and ABO and H blood group system. I would like to acknowledge Dr. Neelam ma'am, who was my ex head of the Department of Transfusion Medicine, PGI Chandigarh, and Dr. Ritiram Sharma, who is the present head of the Department of Transfusion Medicine, PGI Chandigarh. Thank you, sir. Thank you, ma'am. So I will be discussing the topics under the following headings: starting with the introduction, then blood group nomenclature, the importance of antigen study, the terminology, the genetics, ABO and RH genetics, the ABO blood group system, H blood group system, and ending the seminar with the nutshell. So basically, what is a blood group system? So blood group system consists of a group of antigens. So we should have a group of antigens to call it as a blood group system. But not only the presence of a group of antigens made a blood group system. It should be, the antigens should be encoded by a alleles at a single gene locus, and which are so closely tightly packed that the crossing over is not possible. So for any antigen to be a part of a blood group system, it should have a group of antigens which should be coded by the alleles at a single gene, or the gene should be so tightly packed that the crossing over doesn't occur. Then some antigens maybe doesn't fit in a system, so they can be fitted in a series which are known as antigen series. They can be clubbed under the collection. So what is an antigen collection? So antigen collection consists of the antigens that are phenotypically, biochemically, and genetically related, but the genes coding them has not been identified. So the basic difference between the system and a collection is that in the system the gene is identified and there is a single gene which is so closely tied that the crossing over doesn't occur. But in the collection the gene hasn't or has not been identified. Then comes the series. So series is just the antigens which cannot be fitted in the system and the collection. They are comes under the series. I will be talking about in my further slides. So the placement of a blood group antigen into a system or a collection begins with the discovery with an antibody. So with any of the antigen which should be fitted for a system or for a collection or for a series, the discovery begins with an antibody. So first of all, an antibody has to be discovered before being worked up or clubbed, identifying into an gene or clubbing them into the system or the collection. So then, if we have already talked about the system, we have talked about the series, we have talked about the collection. So what is blood group? What is blood group? So basically, the blood groups are the red cell antigens. They are nothing but they are the antigens on the outer surface which are recognized by the immune system of an individual who lack that particular structure. That means if my blood group is A, it means that I am harboring the A antigen on my RBC membrane. And if my RBC membrane is harboring the A antigen, I will be missing the corresponding antibody. The corresponding antibody is anti-A, but I will be having the supplementary antibody, that is anti-B. So the antigens can be classified as proteins, they can be carbohydrates, and again carbohydrates can be glycoproteins and they can be glycolipids. And the corresponding antigens, if we have talked about the antigens which can be proteins and carbohydrates, the corresponding antibodies can be natural occurring or can be immunoaluminized. Natural occurring antibodies, just like we are having anti-A, anti-B, but we are not having anti-D. So anti-A and anti-B are natural occurring antibodies, but anti-D is by the isoimmunization or by the alloimmunization, that we will form the allo antibody only after the sensitization. Suppose, like taking the example of SDFN, the baby is having alloimmunized from the mother. The baby is not harboring that antigen. The baby is harboring that antigen, and mother is not harboring the D antigen. Mother is form anti-D, and it will be crossed over to the placenta, then come to the baby. So baby is having the alloimmunization from the mother. Then what are the guidelines for the establishment of a new blood group system? So for an antigen to form a new blood group system, it must be defined by a human alloantibody. Second, it should be encoded by a gene, and the gene should be identified and it should be sequenced. Thirdly, the chromosomal location should be known. Fourthly, the gene must be different from and not a closely linked homologous of all other genes encoding antigens of the existing blood group system. I will take the example of Abo blood group system, which is the first blood group system. So we already know that if we are classifying the Abo antigens under Abo blood group system, so we have anti-A, anti-B, anti-AB. So we have a well-defined human antibody. The genes we are already encoded. The chromosome location is already known. It is the chromosome number 9. Location is 9q, 34.3. The gene is different. The A gene is different from the B gene, but they are so closely homologous, but the crossover doesn't take place. So for a blood group system, the 4 essential requisites are: you should have an antibody, you should have a gene, we should be identified, we should be sequenced, the chromosome location should be known, and fourthly, the gene must be different from the other gene, and it should be so closely homologous that a crossover doesn't take place. Coming to the basics and coming to the history, the human group systems were first discovered in 1900s, and the first blood group system was discovered by the Lannister. We already know about it, but after 80 years, that is in 1980s, the ISBT established a working party on red cell immunogenetics and the blood group terminology to establish a genetically based nomenclature that is both eye and machine readable, and it is internationally accepted. So we all know, whether it is Pakistan, whether it is Ukraine, whether it is Russia, whether it is USA, whether it is India, whether it is a city, we all know that the ISBT nomenclature is acceptable to every place, to every state, to every nation. So it is internationally accepted nomenclature, which is again automated, that is, it is machine readable, and it is eye readable through the slides, through the golden tubes, and etc. The blood group systems has been incorporated into 43 systems. So I want to just tell you that it is a blood group system discovery is ongoing. You can't say that at the present time today is 4th March 2022. So till now, I have searched on ISBT site that today 43 systems are available, but might be tomorrow or day after tomorrow, might be one blood group system may be added to the existing. So there are at present there are 43 systems, there are 7 collections, and there are 2 series. And series are again divided into 2. That is low incidence antigens and the high incidence antigens. So I have already told you what is the system. I have told you what is the collection. Collection is that is a part forms a group or a bunch of antigens which has for which the genes has not been identified, and the series were those which were not a part of a system, which were not a part of the collection, but they can be divided into a low incidence or can be high incidence. So one may ask me ki, sir, what is the importance of studying the blood group and antigens? So without having a thorough knowledge of blood group antigens, we can't study transfusion medicine, we can't transfuse a blood, we can't do a transplant. So I will tell you one thing, even a blood transfusion is a mini transplant. Why? Because we are transfusing or we are transplanting these cells. We are transfusing red cells. Getting my point? So it is very much important to have the basic and advanced knowledge of blood group and antigens. And the importance lies in the allergenic blood transfusion. So if my blood group is B positive, I will be transfused with the B positive blood group only. You can't transfuse A positive to me because it will cause hemolytic transfusion reaction. I may be killed. I may be murdered. So the basic knowledge is for the allogenic blood transfusion, which I am saying it is a mini transplant. Then the erythrocytes, which have to be tied for the various antigens. Why? Because erythrocytes or RBCs carry an antigen which lack in the recipient. If I am the recipient, I should lack that antigen. If I am not lacking that antigen and somebody is having that antibody, it will be cross-react. It will be incompatible for me, and it will elicit an immune response, and it could lead to antibody formation, and I may die. It can lead to HTR, hemolytic transfusion reaction. It can cause hemolytic disease of newborn, HDN. The study of blood group system is very much important for organ transplantation, whether it is renal transplant, whether it is liver transplant, whether it is heart transplant. ABO antigen are very much important. Though HLA are more important for renal transplant, which are lesser important for liver transplant. But without ABO compatible liver, without ABO matching, no transplant can take place. Though we may decrease the titer, there are exceptions for the renal transplant. But the prognosis is always good when we have matched the ABO antigen between the donor and the recipient. Then the use of blood group antigen study lies in the genetics, in the forensics, and the anthropologic investigations due to its straightforward inheritance from the mother to father and to his son, and a easy detection. Then the prediction of inheritance of diseases which are encoded by the genes in close proximity to the gene encoding the blood group system. That is, I may say there is a phenotype known as acquired B. Acquired B is very closely linked with the gastric cancer, with the pancreatic cancer, with the GIT diseases. There are kid blood group system, there are I may say Duffy blood group system. You already know that it is linked with the malaria. Many blood group system has been linked with the sickle cell disease. Many blood group systems like KIT and Duffy are linked with the urea transporter. In fact, in older days, for the detection of urea receptor, these antigens were typed, because if you have a null phenotype of these antigens, the cell will be so resistant to the hemolysis that it will not lyse. So these blood group systems or the identification of these blood group antigens added to the advantage that you may diagnose the disease. And lastly, it may contribute to understanding of cell membrane structure, how the cell membrane behaves. So this is a very beautiful table which tells the blood group systems and the association with the red cell function. For example, RH blood group system, KIT blood group system, KX is about the KAL blood group system having the KX antigen, the DIGO, the Corton, the GIL, the Augustin's blood group system. the Lannister blood group system, RH blood group system, then these act as a membrane transporters. Some blood groups antigens act as bound antigens. MNS blood group system and well antigen system act as a structural proteins. Duffy act as a cytokine receptor. Lutheran, XG, Indiana, Sienna, they act as a cell adhesion molecules. Cromer, Knox act as a complement regulatory. You have heard about the PNH, CD59, CD55, which are the markers. So these blood group systems are directly linked with the PNH, with the complement regulation. Then we are talking about the ABOH, which we are talking about, which contribute to the integrity of the cell membrane for the glycocalyx. Then coming to the terminology. So the terminology for blood group antigens has been devised by the ISBT, which is the International Society for Blood Transfusion. This is the biggest society. So this society assigns a terminology in 1980s and which is carried till date. So it says it identifies or it assigns a 6-digit number to each antigen. That, for example, if you are having a D antigen, it will have a 6-digit number. The first 3 digit will represent the blood group system. For example, if we are talking about RH blood group system, so RH blood group system number is 4. So we have to write 004. 004 is for the RH system. And the last 3 digits represents the antigen specificity. Like RH blood group system has 55 antigens, and among their 55 antigens, we are talking about D antigen. So D antigen is 001. D antigen is the first antigen in the RH blood group system. So RH code is 004 and 001 stands for D antigen. So for the D antigen, as per the ISBT number, we will write 004001, or alternatively, the system symbol followed by the antigen number may be used, like RH001, or more usually RH1. We may just remove the 0. So we may write, but the standard practice is 004001. So in routine practice, we may say it is RH001 or RH1, which will denote the D antigen. So how does we will tell what is the phenotype, or how will we represent a phenotype? So the phenotypes are represented by the system symbols followed by a colon, followed by a list of antigens separated by the commas. Those antigens shown to be absent are preceded by a minus sign. Taking an example, Cal antigen, Cal blood group system. So we will write this. What is the symbol of the Cal blood group system? It is KEL, Cal. -1 here denotes the absence of first antigen, comma, then it comes the 2. 2 means it is +2. It means the first antigen is absent but the second antigen is present. It is followed by the -3. -3 is that third antigen is absent but the fourth antigen is present. So it tells about the phenotype. So what are the genes implicated in the system? So genes are designated by a asterisk sign followed by the antigen number, which are all italics. So for writing a cal genes, we have to write the cal in italics followed by the asterisk sign followed by the 3. So gene is 3. It is the third gene. How we write a genotypes? So genotypes have the system symbol followed by the asterisk followed by the alleles or haplotypes separated by a slash, and which are again all italics. For example, Cal. Cal is the symbol for Cal blood group system, which is followed by an asterisk sign, which is again followed by a 2. 2 is the allelic number. Then we will follow by, it is again followed by the 3/2. 3/2 is the haplotype. Then it is the 4. 4 is the allele. So the genotype is it is all italics. So the genotype is KEL, Cal, asterisk sign, 2, 3/2. 2 is the allele, 3/2 is the haplotype, 4. So the gene phenotype and genotypes, they are all nomenclatured by the ISBT, and it is an standard practice. We can't remove the italics, we can't put plus minus by ourselves. It is all it's standardized, and it is well accepted all over the world. Antigen, phenotype, gene, and genotype designations for the collections are constructed in the same way. For the collections, the antigens are represented in the same way, but it is somewhat different for the series. For the series, we add 700 and 901. Like for the 700, 700, it represents the low frequency antigens, and 901 represents the high frequency antigens. So whenever we write the series or the antigens in the series, we will remove the symbol of that blood group. We will add 700 for the low frequency and 901 series for the high frequency. Then what are the absolute numbers? So suppose if you will read transfusion medicine older books, you can easily see that there were about 60 antigens in the RH blood group system, but at present there are only 55, because many blood groups antigens were either absolute or they were clubbed with together, known as the compound antigens. So once a number has been allocated to a specific or to a specialty, that number cannot be subsequently used for another specialty. Suppose if you have given 5 to X, you can't, and it has been absolute. So in future, you will never give that number 5 to any other antigen. Consequently, if the number of a specialty becomes inappropriate, then the number becomes absolute. So in simple language, if you have given a number to any antigen at any time and it has been absolute, or you found ISBT found that the gene which was identified forms a series, or it forms a collection, or it doesn't recognize, or it doesn't I can say it doesn't represent that antigen, or it has been heterogeneous in form, then we will remove that gene, but the number of that specific antigen is absolute, but will never be used for any other antigen. So till yesterday, there were 43 blood group systems identified. So the first blood group system was Abo blood group system, which has I may not use my cursor here. So the first blood group system is ABO blood group system. The system symbol used is ABO. The gene name is ABO. You can see which has been written in italics. The number of antigens has been identified as 4. The chromosomal number is 9q34.3. The CD number has not been yet established. So and likewise, RH blood group system has been given the number of 4004, which I have discussed previously. The system symbol was RH. Gene name was RHD or RSCC, depending on the antigen for which the gene has been coding. The number of antigens are 655 till date. Previously, they were 60 plus or 65 plus, but they have been clubbed or they have been absolute. So the number cannot be used for another antigen, but total number is 55. Chromosomal number location is 1. Chromosomal location is 1, followed by the P36.11. CD number is CD240. So and Bombay Group, which we always talk, is represented by the blood group system number 18018. System name is H. It has system symbol of H. Gene code is FUT1. Number of antigen is only 1. The chromosomal location is 19C. CD number is 173. So just appreciate that the blood group system may have 50 antigens, it may have 55 antigens, it may have only one antigen. So basically it forms a system. So a system can have a one antigen, it can have thousands of antigens, it can have 2 antigens, it can have 55 antigens. So it depends upon the identification and sequencing of the gene for that antigen. So the criteria for an inclusion of a new specialty, till now we were talking about the antigen which is new for that system. But if a system has already been established, like I will have an example of Indian blood group system. Blood group system is 23. It has 6 antigens and is codes by the chromosome location at 11q. So previously it has only 5 antigens, but in 2017, Dr. Sanmukh Joshi from India, from Gujarat, identified a new antigen, and it has been named INRA, Indra. So it has been added to the Indian blood group system, and previously it was 5 antigens, and with the INRA it forms 6 antigens. Now it is 5 plus 1, it is 6. So how we incorporate that 6th antigen in that blood group system? So for the identity, for inclusion of the new specialty, the all antigens awarded by the ISBT number must have been shown to be inherited and should have at least one of the following 4 criteria. First, it should have an antithecal relationship. Antithecal relationship, that means that an antigen gene should be present and its homologous should be present on the another antigen. For example, for the Indian blood group system, we have INA and INB. So IN stands for Indian blood group system, A for the one gene and B for the other gene. So INA is homologous or it can be heterologous. It is, but it is antithetical relationship. So, and secondly, it should have the demonstration that the expression of the antigen is associated with the variation in the nucleotide sequence. So, first of all, it should have an antithetical relationship. Secondly, it should have a nucleotide sequence, a variation in nucleotide sequence. If there is no variation, then it may, if there is no variation in the nucleotide sequence of INB, it will be coded as INA. So there should be a variation in the nucleotide sequence. Thirdly, there should be evidence from the linkage analysis of the family data that the controlling allele is probably a newly recognized. So the INRA, which was identified in 2017, it has a controlling allele, which was INR, which was identified as INRA. It was closely resembling with the INA and INB, but it has a antithetical relationship. It has a variation in the nucleotide sequence, and it again has a located at a gene which is and coding for an antigen which was protein or which was glycoprotein, but which was absent with the others. I will make it simple that at present there are 6 antigens: INA, INB 1, 3, 4, 5, and INRA. So this INRA, to be a part of the existing Indian blood group system, it should have an antithetical relationship with other antigens. INRA should have a antithetical relationship with INA or INB. It should have a variation in the nucleotide sequence of the gene. Thirdly, the controlling allele should be newly recognized. If the controlling allele is not newly recognized, then you can't assign that newly assigned antigen to the existing blood group system. Why? Because for the as per the definition of the system, you should have a gene or allele identified. If suppose you are not having an allele or gene identified for that system, and you can still keep that antigen in series or in collection, but that doesn't be clubbed under the system. Getting my point? So what are the collections? So collections were introduced in 1988. In 1980, the ISBT defines the system. In 88, the collection terms was coined. It brings together the genetically, biochemically, and serologically related set of antigens which were, but for which the gene identity was not known. So till present, there were 13 collections, which were 205, 207, 208, 209, 210, 212, 213, 201, 202, 203, 204, 206, 211. What are series? Series are the antigens that doesn't fit into a system or a collection. The series can again be identified as 700 series or the 900 series. 700 series are the low incidence antigens and the 900 series are the high incidence antigens. So for the low incidence series, taking the example of CW, we have 18 antigens in low incidence series, and for the high incidence series like capital E, we have about 6 antigens. So what are the inclusion criteria for series? For the 700 series, the incidence should be as low as less than 1% in the most population tested. And it should have a distinct from other numbered low incidence antigens of 700 series as well as those of the blood group systems and collections, that the number should be different, that it should demonstrate a inheritance. So in nutshell, how will you count a antigen in a 700 series? For clubbing or for putting an antigen in a low incidence series known as 700 series, the incidence of that antigen in that population should be less than 1%, and it should demonstrate an inheritance from the mother to his son. Getting my point? And from the son to his offspring. So at least 2 generations should have that inheritance. Examples are Betty, Christian, Bills, Box, many. What is 901 series? 901 series are the antigens which are which are labeled as high frequency antigens. Example is VEL, SID, Augustine blood group system. Sorry, Augustine blood group series, not system. So these antigens which we put in 901 series or in high frequency antigens, they should have incidence of greater than 90% in that population, and demonstration of that antigen is lacking from the red cells of at least 2 siblings. That is, you should have a negative phenotype in a genetically determined population. So in 70 series, we were having that the 2 generations should express, the inheritance should be clubbed, should be known. But for the 901 series, it is not talking about the generation. It is saying कि in a particular generation, at least there's 2 siblings of that family should be lacking that antigen. Then only we can say it is high frequency. But it should be again expressing in other antigens, in other family members. Suppose if a mother father is having 10 sons, 6 plus 4 daughters, 6 sons and 4 daughters. So from that 10 siblings, at least 2 should be lacking that antigen, and 8 siblings should express that specific antigen. Then only we can say it comes under the high frequency antigen. So what is cluster of differentiation? So the cluster of differentiation, which is abbreviated as CD, is a protocol for the identification of cell surface molecules that provide the targets for the phenotyping of cells. So basically CD, as you already know, it is a protocol. It identifies these cell surface molecules which are the targets for phenotyping the cells. By for PNH, which I was talking, CD59, it was the marker of, CD55, CD59. These were the marker for complement system, but they are again a marker of some blood group series, some collections, some systems. So the CD molecules are for the identification of that molecules. The CD molecules may act as a receptors, or they may have a role in the cell signaling, like a cell signal. Like again, I'm taking about the same example of uh, complement system. Is CD 59, 58, 55, which is a marker, which is a receptor for the PNH. It has a role in cell signaling for the complement activation. And lastly, the CD molecules carry the blood group antigens like MN blood group system. So in the MN blood group system, we have which again activates the complement. The antibody may are about 50% of the cases it is IgM. In 50% cases it is IgG. It activates the complement, so it carries the antigens. So the CD molecules for the MNS blood group system may or MNS has four antigens M, N, S, S. So these antigens were identified. They act as a receptor. They act as a signaling molecule for the system. So coming to the main topic about the what is ABO and H blood group system. I am taking ABO and H blood group system, though they are two different identities. They belong to two different systems. ABO is the first blood group system. H is the 18th blood group system. But I am dealing. But I am talking these two blood group systems simultaneously. Why? Because they are very closely related, and they have biochemical and phenotypically so closely related that without H blood group system we can't talk ABO blood group of blood group system. So Lannister discovered the ABO blood group system in 1901. He and his five other co-workers began mixing each other blood groups and serums and accidentally performed the first forward and reverse blood grouping. So Lannister basically discovered the ABO blood group system, and his followers later on discovered the RH blood group system. So Lannister rule is that if an antigen is present on a patient red blood cells, the corresponding antibody will not be present in the patient serum under the normal circumstances or conditions. That means if my blood group is A positive, I will be having A antigen, but I will not be having that antibody. I will not have an anti-A under normal conditions. If I will be having anti-A, it is not normal. I may die. Why? Because my anti-A will agglutinate with my A antigen, and you may label me as the auto anti-A. Like we have AIHA, autoimmune hemolytic disease of autoimmune anemias. In what happens in autoimmune anemias, we have the antigen and we have the antibody to that antigen, which agglutinates and lead to the progression of the disease. So what are the importance of ABO blood group system? So basically the importance lies in the two principles. First of all, the ABO blood group system is universal and the antibodies are naturally occurring. Secondly, these antibodies which are naturally occurring are mostly IgM, and that means key IgM reacts at lower temperature and has a tendency to activate the complement. So and one interesting thing is that almost all the normal individuals till the age of 6 months, matlab the neonates or the infants till the age of 6 months, though have the antigen, they have ABO antigen, but it might not be expressed. This is this line is very important, which I am telling you, because till the age of 6 months, if we are typing an infant as a weaker subgroup of A, for example, it is we can't comment whether that individual or if that infant is having the weaker subgroup or not. Why? Because that these antigens develop till the age of 8 years. The antibody develops maximum after the 6 months of age, and the antigens best develop at the age of 8 years. So the inheritance pattern. So basic definitions, the what is isoagglutination? So isoagglutinins are defined as the antibodies that agglutinate the blood cells of some individuals of the same species. Glycosyl transferases are the enzymes that facilitate the transfer of carbohydrate molecules onto the carbohydrate precursor molecules. So isoagglutinins are the antibodies. Agglutinins, these are the self antibodies. Sorry, not self antibodies. They are the isomies of the same species. These are antibodies from the same species. And that when we are talking about the transferases, we're talking about the enzymes. Then we have something called as immunodominant sugar. So immunodominant sugars are the sugars which forms the a base one network for the antigenic determinants, which will be when combined with the precursor molecules, which when combined with the precursor molecules will give us the antigens. I will tell you in further slides. So we know what is isoagglutinins, we know what are the transferases, we have the immunodominant sugar. So what are the ABO genes? So basically the ABO genes are located on chromosome number 9. We have already known about it. The inheritance in the ABO system is controlled by the various alleles. Four common alleles are A1, A2, B and O, and a series of rare other alleles like A3, AX, AM. I just want to tell ki I am just talking about like A3, AX, AM. These are the weaker subgroups of A antigen. A antigen is like an umbrella. If we are if my blood group is A, it is not purely A. I may be A1, I may be A2, I may be A3, I may be AX, I may be AM. In 80% of the conditions, I may be A1. In the rest 15 to 18%, I may be A2. But in lesser proportion, I may be A3. I may be AX. I may be AM. I am A positive, but I have a weaker subgroup of A. So ABO blood group system, the beauty of that ABO blood group system is that it is controlled by the various alleles. Common one are A1, A2. A1 for 80% of the times it is A1, 15 to 18% is A2. And this 80% and 15 to 20% I'm talking about the A antigen. And then it comes about the B and O alleles. And the rare alleles for that A antigen is A3AXM, with a total of 280 alleles in a single ABO blood group system with the 537 variants. So this is the beauty of the ABO blood group system basically. So we know what is A allele, what is B allele, what is O allele. So basically O allele does not produce any antigenic product. It is a recessive, and it is recessive to A and B alleles. And A and B alleles are co-dominant. So basically the inheritance of A and B genes is co-dominant. So basically if you are having the A antigen, you may be like in the last line I have typed for example the phenotype is A1. So it can have the several genotypes. You may be A1, you may be A1A2, you may be A1A3, you can be A1AX, you can be A1AM, or you can be A1O. So A1 is a broad umbrella, and on that broad umbrella you are having several phenotypes. You can have several genotypes. So this slide tell about the major blood group system ABO, in which I have depicted the forward blood grouping using the anti-sera and the red blood cells. In the ABO blood group, I am having A, B, O, AB. In the antigens present for the ABO blood group A, I am having the A antigen, and I will be missing antigen will be B, but the antibody will be anti-B. For the B blood group, I will be having B antigen present and the anti-A present. And for the O blood group system, O blood group, I am having no antigen present. No antigen present means I am having no ABO antigen present. I may be having antigen of other blood group system on O, but I am lacking AB antigen on O. I may be having M. I may be having Indian blood group system. I may be having D antigen on O, but I am lacking A and B on O. So the antigen missing are A and B. Okay, and the antibody present are anti-A and anti-B. And for the AB blood group, we are having A and B both antigen present on the red cells, and we are having the nil or no or none antibody present in the serum. So this we are talking about the ABO blood group system only. Out of 43 blood group system, I am talking about ABO blood group system ki on AB or on O or on B or on A, we are having A antigen, B antigen, AB antigen. We might be having other antigens also. So please make it clear कि for O and for blood group O, we may have other blood group antigens present on O cell, but it will be absent only for A and B. It may be absent for other blood groups antigens. It may be present. The other blood groups antigens may be present or absent. It depends. But for to be called O, A and B antigen should be absent. So if an antigen is present on a patient red cell, the corresponding antibody will not be present in the patient plasma under normal conditions. I am writing what are, and I've already told you what is normal conditions by giving the example of AIHA or human hemolytic anemia. In AIHA, you may have the corresponding antigen and the corresponding antibody, but under normal conditions, if you are having an antigen, you will not have that antibody in your plasma. So this is the forward and reverse blood group. So in transfusion medicine, basically I always say that transfusion medicine is full of paradox. It is full of controls. So even for a simple blood group, in documenting a simple blood group, we use at least 4 controls. So for the forward grouping, so what is the I should tell you what is the forward grouping. So for the forward grouping is when you are mixing the red cells. See, you have the sample, EDD sample, you centrifuge it, separate the red cells and the plasma. That red cells will work for the forward grouping and that plasma will work for the reverse grouping. On that red cells, we have antigens. We have unknown antigens, which will be typed by the known antisera. The known antisera can be anti-A, anti-B, anti-D, or anti-AB. So if that unknown antigen, to know that unknown antigen, we should have the known antisera. For example, in this case, we have unknown unknown antigen which is present on that red cells. We put that red cell in anti-A, it gives 4+ reaction. That means that A antigen is present. But when we put anti-B, it gives negative reaction. It means that B antigen is missing and A antigen is present. So the blood group of that patient or donor is A. Anti-D tells about the D antigen, or anti-B tells about, basically we are cross-checking the A antigen with anti-AB. So if A antigen is present, anti-AB will give the reaction. If B antigen is present, it will give the reaction. But if A and B antigens are not present, anti-AB will give negative reaction. But opposite happens in reverse grouping. So in reverse grouping, we are having the plasma, and in the plasma we are having the antibodies, but these antibodies are unknown. So for that unknown antibodies, we should have the known antigen to be typed. So what we will do, we will take the plasma from the patient, and we don't know what antibodies are present, whether it can be anti-A, it can be anti-B. but for that we will put that plasma, we will add the red cells with the known phenotype with that plasma. And for if that red cells, which we will call, which are definitely pooled cells, if these pooled cells give the reaction, we can say that that plasma is having that antibody and reacting with that antigen. For example, just focus on the reverse grouping. Ki B cells are the known cells, and you are adding the anti-sera of the unknown antibody, but it is reacting with the B cell and it is not adding with the A cell. Then you can say keep that patient or donor is having anti B. The patient or donor is not having anti A, it is having anti B, and anti B will be will present in the serum or in the plasma only when the patient or donor is A. Now focusing on both, if the blood group is A, antigen is A, so in the reverse grouping it should not it should be absent for the A antigen, and it should give the reaction with the B cell. That is, the antigen is A and the antibody is anti-B. A antigen is detected in the forward grouping, and in the reverse grouping we identified the complementary antibody, which is anti-B. So A antigen individual will have anti-B antibody. If in the forward grouping you are getting the reaction with the B cell and A cell both, so accordingly the reverse grouping should have negative reaction with the A cell and with the B cell. But you should ask, sir, you were telling about the controls, where we are putting the controls. So in this simple test we have put 4 controls. The first control is forward grouping and reverse grouping. If the forward grouping is not complementary to the reverse grouping, the test is invalid. Suppose in this example, if anti-A anti-sera is giving 4 plus reaction in the forward grouping and A cell is positive, that means it is not complementary, because as per the Lancaster law, if you are having A antigen, you should not have anti-A. So the first control is forward grouping with its reverse grouping. The second control is anti-A-B, which you are using. Anti-AB anti-sera should react only when you are having A antigen or B antigen or both. If you are having O blood group, then anti-A anti-sera and anti-B anti-sera should be negative, and anti-B should again be negative. If anti-A anti-sera and anti-B anti-sera are negative but anti-AB anti-sera is positive, that means your test is invalid or you are harboring some kind of subgroups. Getting my point? The third control is O cell. O cell means you are in normal conditions, O cell should be negative. Why? Because O cell harbors anti-A and A antigen or B antigen. So if the O cell should not carry A antigen and B antigen. But if your O cell is positive, that means ki accept A and B antigen, you are harboring an antibody against some blood group systems. Getting my point? I am telling you again ki O antigen, ki O group means O cell means you are having no A and no B, but you may be having some other antigens for some other blood group systems. So if O cell is positive, that means you are harboring an antibody against some other blood group system except A and except B. And if it is negative, that means you are not harboring A and B antigen, and also you are not harboring that antigen which you are testing with that antibody. I'm not going to confuse you more. कि in normal conditions always remember कि for the O cells under normal conditions it should be negative. If it is positive, that means either you are having some kind of auto antibody or you are having some kind of allo antibody. That means allo antibody means that your patient or your donor might have been transfused or has or and after transfusion or after sensitization he has formed a antibody which is harboring in that with that cell with the O cells, and that O cells, if we are taking that O cells to 37-degree or AG phase, it is known as ICT or indirect Coombe test. My fourth control is auto control. So as per the Lannister, what he says ki if you are harboring the A antigen, you should not have that antigen. So under normal condition, auto control should also be negative. If your auto control is positive, that means you are harboring an antigen and an antibody directed against that antigen. So my four controls for a blood grouping is the forward grouping should be complementary with the reverse grouping. First, second, anti-AB anti-sera should give the complementary results. It should be negative or it should give no results with the O cell or O group individuals, but it should give the same strength or same result when you have typed the A antigen oblique or B antigen. The O cell should be negative, auto control should be negative. If O cell is positive, that means you are harboring allo antibody or you are harboring auto antibody. And for that auto antibody, your auto control should be positive. So in normal conditions, O cell should be negative and auto control should be negative. And what about how we will document the blood group? We will write A RSD positive. So in this blood group, in this report, I am depicting the two blood group systems. My A denotes the A blood group system, which is the first blood group system. A is from the first blood group system, and RHD means from that 55 antigens from the RH system, only D is positive. So you say कि your blood group is B positive or A positive, it means that you are telling or you are documenting the two blood group systems. First is A blood group system from the ABO and RHD blood group system from the RH, and from that RH blood group system you are telling that you are harboring only D antigen. If it is suppose you are O negative, so O negative means you are having O antigen, you are having O group from the ABO blood group system, and RHD is negative, D antigen is negative from the 55 antigens for that individual. So it is O RHD negative. So some basics about the antigens. So what are antigens? Antigens can be glycoproteins, they can be proteoglycans. So some biochemistry for it. What are the glycoproteins? So glycoproteins are the oligosaccharides. Basically, they are the carbohydrates with the proteins which are linked to the proteins molecules by the glycoside linkage. So they form a linkage. So basically, the carbohydrate forms a linkage with the proteins. Okay. So it is known as the glycoprotein. So what are the proteoglycans? So the proteoglycans are the proteins which are covalently bond with the glycosyl aminoglycans, GAGs. So whenever the GAGs are covalently linked with the proteins, covalently bond, they are known as proteoglycans. And what are the GAGs? The GAGs are the repeating sequencing of the sugar of the disaccharides of an which are the amino sugars or an unique acid. So don't be confused. Just remember the glycoproteins are the carbohydrates which are linked with the proteins, and the proteoglycans are the proteins which are covalently bond with the repeating units of the sugar. That's it. This is the pictorial diagram of glycoproteins, because my antigens can be glycoproteins, they can be proteoglycans. I will be talking in details in my further slides. So this pictorial diagrams tell about the this is the RBC membrane and my antigens. So you can say that my antigens can have a single pass protein structure, they can have a multiple antigen protein structure like the haywire, or they can be put just simply on the RBC membrane. For example, Louis A, Louis B, P1 antigen. You can see that these are on the RBC membrane, but few antigens like ABH, they span around the RBC membrane. They form, but they are only single pass proteins. There are many multi pass proteins also, which form a surpass from the RBC membrane, that they come out, then they again go into the RBC membrane, then they again form ye come out. So the difference between these single pass protein, multi pass protein, or the antigens which are located on the RBC, these are very important. Why? Because some of these antigens form the receptors of some bacteria. They can form the receptor of some I was talking about the urea receptor. They can form a receptor for the malaria, and many more. So how does the antigen form? So for the formation of an antigen, we are having four types of chains. So what are these chains? These chains are type 1, type 2, type 3, type 4. We are having type 5 also. But for this present class, I will be talking about the type 1 and type 2 chain only. Type 3 and type 4 chains are more commonly presented on the renal endothelium. Type 1 and type 2 are present on the endothelium of every blood cell, of every blood vessel lining. So how the type 1 and type 2 differs? So the type 1 and type 2 differs by the linkage. Type 1 linkage is beta 1,3 linkage. In I will tell you, you can see in this slide type 1 is having a linkage with the galactose. GL is the galactose, and this NAC is N-acetyl galactosamine. So the galactose B1 position carbon atom is linked with the third position of the N-acetyl galactosamine, and in type 2 the linkage is B1 to B4. So only the linkage differences between the type 1 and type 2. This simple linkage difference, see, the type 1 and type 2 difference is only for the linkage, only from the 1B linkage to the 3 or 1B B1 linkage to the 4. But this makes a lot of difference. Why? Because the type 1 linkage is present in the secretions and type 2 linkage is present on the RBCs. 3 and 4 can also be present, but type 1 is absent on the RBCs. So just by changing the carbon atom position from the 3 to 4, whole scenario change. For the type 1, remember, it presents in the secretions, and type 2 is present on the RBCs. So the inheritance of the ABO blood group antigens or the blood groups demonstrate that each individual should inherit one ABO gene from each parent. That I am harboring one gene, at least one gene from my each parent, one from my father and one from my mother. And these two genes, when clubbed together, form the determinants for the antigens which are present on the RBC membrane. But remember, these antigens, though code for the antigens, does not form the antigens. These antigens, these genes which code for the antigens does not form the antigen. Basically, the genes like A gene forms the enzyme which forms the antigen. So basically, the sequence is the gene which forms the enzyme acts on the substrate and forms the antigen. So any gene, ABO gene, does not form any antigen. It codes for the antigen, but it does not form the antigen. There are two things separately. So the one position or locus on each chromosome number 9 is occupied by a gene, whether it is O gene, whether it is B gene, or it is A gene. A single local focus is should be present. So how you define a locus? So a locus termed H, and the final product of that gene at that locus determines the antigen through the enzyme. मतलब in subsequent slides I am telling you with an example कि मतलब see we were talking about the ABO system. Now we are talking about the ABOH antigen. We are not talking about ABH blood group system. Why? Because ABO blood group system is different, H blood group system is different, but they are closely related. Gene is different, enzyme are different, everything's are different, but they are very closely related. There is ABH antigen, but there is not ABH blood group system. So don't be confused. But I will like to tell you that the substrate for the A antigen or B antigen or AB antigen is the H antigen. Only if the H antigen is absent, ABO antigen can't be formed. If H antigen is present, it will form the base for the enzyme to act on the substrate and form the A and B antigen. So A, B, H antigens on the RBC membranes can be glycolipids or they can be glycoproteins. It may also occur in the secretions as glycoproteins, but the exception is CSF. In the CSF, we doesn't found any antigen. So antigens belonging to the ABH blood group system are present on RBCs and other blood group cells and body fluids, except CSF. The presence of A, B, and O antigens on or H antigens on the RBC depends on the allelic genes and the ABO or H genetic sequence or the genes harboring from the patient, from the mother or father. An H gene at a separate locus codes for the precursor substance on which the A and B gene products act. Means कि H gene codes for the enzyme which forms the H substance, and on that H substance the A gene codes for the A enzyme, and that A enzyme will act on the H product and form the X blood group. The product of the A gene and B gene are the enzymes that act as a specific transcriptase. What I was telling you, कि the genes are coding for the enzymes and that enzymes are forming the antigens. The genes are coding for the enzymes and for the antigens indirectly. So genes are coding for the enzymes, but the enzymes are coding for the enzymes and for the antigens. But those antigens are not directly a product of the genes. The antigens are the product from the enzymes. So H gene. So always remember that H gene products is an enzyme that produces the H substance. H gene produces the enzyme, and that enzyme will act on the precursor substance and form the H substance. And on that H substance, the product of the A gene or B gene or AB gene will act and form the corresponding enzyme, and that corresponding enzyme, for example A enzyme, B enzyme, AB enzyme, will act on the H substance and form the corresponding blood group. O gene is silent and amorphic. What is amorphic? Amorphic means कि it has lost the ability to form a fruitful or a functional protein or an enzyme or anything. मतलब कि it has lost the ability to function. It has lost the ability to produce a functioning protein. So O gene is a silent allele and it does not alter the S substance. Okay. So coming to the genetics. So the presence or absence of the ABH antigens on the red blood cell membrane is controlled by the H gene. Secondly, the presence or absence of ABH antigen in secretion is indirectly controlled by the SC gene. Now, what is SC gene? SC gene is the secretory gene. I told you we are having antigens in every secretions except the CSF. So, for the red cell membrane, it is controlled by the H gene, because if we are not having the H gene, A gene, A gene enzymes, which the enzymes which were coded by the A gene will not act. But if we are having and if we are and correspondingly, if the S gene is absent, then we may say the patient or that individual is non-secretor or secretor. So basically, the H gene is coding for the red cells and SC gene is coding for the secretions. So for a gene and for a haplotype, we are having HH, and H is amorphic. I told you that it is not, small h is not functioning. So basically, the capital H, small h gene has capital H and small h alleles, which are controlling the presence of H, A, and B antigen on the RBCs and the secretions. You will tell you, but you may ask me, sir, you were saying that secretions were controlled by the SC gene. Definitely, RBC, because see, RBCs are in the close relation with the plasma. So if the secretory gene is present, the antigens, the red cells will absorb that antigens from that plasma. Okay, and the RBCs will only absorb the antigens from the plasma if it is having the H gene. So if we are having the H gene, it means the H gene is controlling the H antigen, A antigen, and B antigen. Why A antigen, B antigen? Because A group or B group or A antigen and B antigen only be formed when H antigen is present. If H antigen is present, you may have A and B gene, but you will not be able to form A and B antigen or blood group. This is the case in Bombay, in which Bombay Group is deficient in H gene. You may have A gene, you may have B gene, but it will not be expressed because the enzymes will not act on the S substance. S substance is lacking. Getting my point? Secondly, what is SE gene? SE gene again has capital SE and small SE. Again small SE is amorphic, and that SE gene controls the presence of antigen in the secretion. So H gene controls the secretions in RBCs. SE genes control H gene controls the presence of HAB antigens on the RBCs and the secretions. SC genes control the presence of H antigen in the secretion, and the ABO genes, whether it is AB or O, they control the presence of AB antigens, and each gene should be carried or should be inherited from each parent. So how does H antigen form? So so we have a precursor substance. Precursor substance is galactose B1 towards the fourth carbon atom of the glycosyl and galactose and acetyl glucosamine, and it is linked to with the 1,3 linkage to the galactose. So between the two galactose, we are having an acetyl galactosamine. So this is the precursor substance. On that precursor substance, we have the H gene, which adds fucose at alpha 1 2 position to the galactose. So the fucose is added to the galactose and H substance is formed. So in the box, I have told you that the galactose is linked with the N-acetyl glucosamine to the 1,4 linkage, which is linked with the 1,3 linkage to the other galactose. That is between the two galactose, we have N-acetyl glucosamine, and these when acted upon by the H gene through the transferases. The enzyme is, and which transferase? It is fucosyl transferase. That fucosyl transferase acts the fucose sugar to the galactose at the alpha 1 linkage that from the H substance. So H antigen is the foundation for the A and B antigen, and the A and G and genes code for the enzymes that add an immunodominant sugar to the H antigen. This means कि in this slide I have told you कि if just see कि fucose is added to the galactose through the alpha 1 linkage. ठीक है, we are having the precursor molecule galactose and acetyl glycosamine followed by the galactose, and fucose is added at the 1-2 linkage. On that linkage, if uh, an acetyl glucosamine is added to the alpha 1 and 3, it forms the N antigen. Getting my point? If fucose is not there, or in other words, if the H substance is not there, that enzymatic product, the enzymatic product is an acetyl D-galactosamine is not attached with the galactose. So, if you are harboring the A gene and that A gene is making an enzyme, A enzyme, or the transferase, which is coding for the and which is forming the substance N-acetyl D-galactosamine. That N-acetyl galactosamine will not be attached to the galactose till you are having or till the fucose is attached with the galactose. See, same on the same principle, कि you are having the H substance, and on that H substance, the B gene product. And what is that B gene product? Is the D-galactose. For the A, we are having an acetyl D-galactosamine, and for the B, we are having the galactose. For that galactose to be represented as B antigen, it should be attached to the H substance, and H substance is formed by the fucose attaching to the precursor molecule. So, taking
I'm sorry to just bother you here. I think we are just crossing the time
okay, sir.
here. So, how do we go about it? Should we stop here and then the rest
Sir,
of
I
the
will
day we
take only
continue?
10 minutes if you permit, sir.
Okay, no problem. Please go ahead.
Yes, sir. So I will run through. So basically, this is the simplest slide. Ki we are having the H antigen which is formed by the galactose and N-acetyl glucosamine. And when the fucose is added, we are having the H antigen. And on that H antigen, if the N-acetyl galactosamine is attached, it is the A antigen. And if it is galactose is attached, it is the B antigen. Again, the same thing. So this is again the table showing, just clarifying you कि when the fucose transferase is the name of the enzyme for the H gene is the fucosyl transferase. For the A gene, it is the N-acetyl galactosamine transferase, which is adding the N-acetyl galactosamine sugar to the S substance. And for the B gene, we are having the galactosyl transferases, which is adding the galactose to the S substance. So now comes to the H deficient phenotypes. So basically, H deficient phenotypes is the Bombay blood group system basically. So although ABO and H systems are two different blood group systems, genetically ABO, which is numbered as 001, and H, which is numbered as 018, they are closely related to together at the biological, chemical, and the phenotypic level. The H deficient phenotypes are very rare and include a total deficiency in H antigen, which is denoted by the phenotype as capital O and small h. So OH depicts the phenotype of Bombay blood group. Then we have partial deficiency known as the partial Bombay phenotype. So the H deficient phenotypes are those rare phenotypes in which the RBCs are completely devoid of H antigens, or they have a small amount of H antigen present. If it is completely devoid of H antigen, it is the Bombay phenotype, and if it is partially deprived, then it is the para Bombay. So basically, what is basically the phenotype of Bombay or O is same, but serologically it differs. Phenotypically it is same, serologically it is different, genotypically it is different. So in routine, if you are just doing the forward team phenotype, you will get the O for the O group and O for the Bombay group. But the importance lies in the identification of the Bombay group by doing the reverse grouping. In the reverse grouping, the Bombay individual will harboring an special antibody which is anti-H. I told you कि H substance which I was telling you, if the H antigen is absent, then the patient or individual will form an anti-H because the antigen is absent. He will form anti-H, and for a compatible match, you should match a anti-H with the H deficient. Getting my point? So in reverse grouping, you will get the reaction with the A cell, B cell, O cell. Why? Because all the A cell, B cell, O cell will be formed on the H precursors, on the H antigens, and you will find a compatible unit only when you are not harboring an H antigen. That is your Bombay group. So the Bombay group will have a compatible match only with the Bombay group, no one other else. So in the Bombay group, we have three type of categories. So category one is the RBC, which is H deficient and is non-secretor, which is pure Bombay phenotype. That is, it is small h and small e SC. So Bombay phenotype is non-secretor and H completely deficient. So basically the H gene is very common and is 99.99% cases it is present, and is only sometimes it is deficient, but it is more common in our population like in Maharashtra, in Bombay, from where it has been derived the name as Bombay phenotype. So conversely, the H allele is very rare and does not produce the fucosyl transferase which is necessary for the formation of the H structure. The Bombay phenotype or the OH inherits the HH genotype and therefore lacks the normal expression of the ABH and antigens. You may be harboring A and B genes, you may be having, but the product of that genes through the enzymes is the antigens. It will be not be present serologically. That is, if you are typing, see, a Bombay can have A group, but serologically it will not be expressed as A because this substance is lacking, and on that S substance A and B antigens will be lagged. But if you are doing the molecular grouping of that individual, you may say, yeah, it is Bombay A positive, Bombay A group, Bombay B group. Second category is RBC, which are H partially deficient and are non-secretor. So these type of RBCs of these individuals express the weaker form of the A and B. If you are having a complete deficient H, A and B will never be formed. But if some H is present, a weaker form of A and B can be present. You may not have a 4+ reaction, but you may have a 1+ or 2+ grade of reaction, which are primarily detected by the adsorption and elution. Adsorption is you are absorbing the sera on the known cells and then you are eluting it. Eluting it, that you are removing the antibody from that antigen by a special method. If a person is genetically A or B, the respective enzymes can be detected, but no H enzyme is detected, even though it has been shown that there is a limited production of H antigen on the RBCs. See, there is no H enzyme, but there is some amount of H substance present on which A and B genes are acting upon. So that phenotype will be depicted as A small h. For the A group, for the B group, it can be BH respectively. If the individual is having a AB blood group, then plus H deficient phenotype, then it will be labeled as ABH individuals. No H, A or B individuals is present in the saliva. Why? Because the individual is a non-secretor, is not harboring the SE gene. The serum of AH individuals will contain anti-B and no anti-A, same as we have talked about previously. Although anti-A1 is usually present. So what is anti-A? Anti-A1. What is anti-A1? I've already told you that A is just like an umbrella. It has many antigens A, B. So basically A1 and A2 differs on the H antigen. So A antigen has a type 1, type 2, type 3, type 4, all four type of substances present, but A2 may present only type 1 and type 2. It may be lacking with the type 4 and type 3. So it is about the, if you are lacking an small amount of antigens, the body will sensitize that you are not harboring that antigen and it will form an antibody. So an AH individual though will not form an anti-A. Anti-A is anti-A1 plus anti-A2 plus anti-3 and all the antibodies, but anti-A1 is only directed against A1 and antigen. Same case is with the BH serum. Anti-A is always present and anti-B may be detected. Anti-B will be directed only against B, not against BH. So, it is postulated that the homologous inheritance of mutant H of FUT1 gene codes for the production of low levels of H transferase activity. The small amount of H substance on the RBC is completely used by the A antigen or B transferase enzymes. This results in the small quantity of B or A antigen present on red cells with a no detectable H antigen. If in normal circumstances, if you are typing A antigen, ठीक है, so you will give the you can have the reaction with anti A and anti H anti serum. But if you are having a partially H deficient individual, he can give the reaction with weaker reaction with the anti A, but the anti A but no reaction with the anti H. Why? Because all the H antigen has been used in the formation of A or B corresponding antigen, but he may have an antibody against that, which may be again stronger or it can be weaker, which is known as the anti-H, which is IgM type with a wide thermal range. So again, this is just a pictorial diagram in which I have classified the H deficient into three types. The red cells with the H deficient together with the non-secretory status, which is the Bombay type. It is second class category is the H partially deficient and is non-secretor, in which we can have AB antigen in the weaker form, but anti-H and anti together with the H anti-H antibody, but H antigen may be totally absent. Then third is the you are having a weak or some kind of or some amount of H antigen or partially H deficient together with the secretory status. So because of secretions present, the RBC membrane will absorb the antigens from the plasma. So you can have H antigen, you can have B antigen, you can have A antigen. The difference between the category 2 and category 3 is the non-secretory and secretory status. In the category 2, the individual is non-secretory, and in category 3, the individual is secretory. And because of that secretory status, H antigen is present, and in second category, the H antigen is absent. Same I have told in the slide. So in nutshell, so in addition to being expressed on the red cells, AB antigens are also expressed on most other tissues as glycoproteins and glycolipids, soluble blood group substances of same ABO group as the red cells may be found in the serum or in the plasma, or it may be detectable in the saliva, except CSF. The secretory status is controlled by the SC gene, by the FUT gene, most commonly known as, and it is present on the chromosome number 19. The SC gene is the dominant gene which is responsible for the secretory status. Approximately 80% of the general population are secretory. There is no SC, no allele, therefore no SC, because SC is the dominant gene basically. So as there is no SC product in the absence of SC gene, that individual will be known as the non-secretor, and these population form a 20% of the total population amount. So the unique features of ABO and H system are that it is a critically unique feature of ABO and H blood group system, that unlike other blood group system, the anti-A and anti-B and antibodies are invariably present, or they are naturally occurring. And as the ABO-H antigens are widely distributed throughout the body, the ABO blood group must be considered for the organ transplantation. And some organs like the heart must have ABO compatible with the recipient. In fact, all the transplantation ideally should be EBO compatible, but there are exceptions because of the unavailability of the donor. We may cut down the titer through the plasma exchange and we may do the transplant like we are doing the renal transplant. In the bone marrow transplantation, EBO incompatibility is accepted because of the lack of the expression of the EBO on the stem cells, but precautions must be needed, such as the removal of the unwanted donor red cells or the plasma during the transfusion or during the harvesting of these products. Thank you so much. Thank you.
Thank you, Dr. Anubhav. Sorry for hurrying you up for the last few slides. Uh, Actually, it was a very nice presentation and very detailed out. I mean, this is something we really need to understand. I think we all need to go back to this presentation and see it again and again.